No, sir, you can start.
We are going
Sure.
live in 3, 2, 1. You may start, sir.
Good evening, ladies and gentlemen. Today is a very important day. We conclude today 1 year of this interesting web academic series, Blood, the Life Savior. So today we celebrate, along with this academic feast, first year of a nationwide hematology learning movement on blood. Ladies and gentlemen, this has been possible because of the two gentlemen you see on the screen, Professor Dr. Biju George sir and Professor Dr. Joseph Zahn sir, and we just can't thank them enough. It's been their untiring work, and I just told them that the magnet behind this Blood Web academic series has been them. The journey started, ladies and gentlemen, on 15th of January 2025, and we intended to have it on third Wednesday of every month. The unique point was real cases based discussions led by leading institutes, giving opportunity to all the hematologists and those interested to collaborate. Biju sir and Joseph sir, we can't thank you enough. You guys have really pulled off something which is so difficult to pull it off. At the same breath, I would also like to thank 10 of 12 of us who have been instrumental. Apart from Dr. Biju Jorga and Dr. Joseph Son, Dr. Sharad Damodar, Dr. Neeraj Siddharthan, Dr. Dinesh Burani, Dr. Tulika Seth, Dr. Cecil Ross, Dr. Mukesh Desai, Dr. Aruna Rajendran, Dr. Arihant Jain, and Dr. Revati Raj, and today's Dr. Chandran Nair and their wonderful team who developed the interesting case study. Their alma mater, their institute, CMC Vellore, CMC Ludhiana, Narayana Health Bangalore, Amrita Institute of Medical Science, Rajiv Gandhi Cancer Institute, AIMS Delhi, St. John's Medical College Bangalore, BJ Wadia Hospital for Children Mumbai, Madras Medical College Chennai, PGI Chandigarh, Apollo Hospital Chennai, and today Malabar Cancer Center, Kerala. We would like to develop a repository with your kind permission so that a lot of young students doing DMDNB can use it. So we are just presenting a short video clip talking about our first year journey of blood, the life savior. Over to studio, please.
Every great movement begins with a question. What if we could bring the brightest minds together on one platform to learn, to discuss, and to save lives? The idea of blood, the life savior began with a vision shared by two pioneers of academic excellence, Dr. Biju George and Dr. Joseph John, whose passion has always been to empower the next generation of clinicians. This wasn't just a webinar idea, it was a mission to create India's first truly academic, case-driven, national movement dedicated entirely bleeding disorders. In December 2024, this thought turned into a blueprint. What if, once a month, an institute from anywhere in India presented a real, complex, practice-changing hematology case? What if DM and DNB students across India could attend, learn, and interact? What if we could turn learning into a shared national experience? And so the format was created. One Wednesday each month, one institute, one real case, 1 hour of pure academic exchange. With hematology at its core, students from every corner of India, north to south, east to west, join this platform every month. Not as spectators, but as contributors to a national classroom, and leading them with the greatest minds of our country, professors, scientists, clinicians, each bringing decades of wisdom to one shared screen. In just 1 year, Blood, the Life Savior became more than a webinar. It became a community, a movement, a classroom without walls, a space where learning is shared, where knowledge travels instantly, where young clinicians grow, guided by legends. And today, as we celebrate the first anniversary, we look back with gratitude to every institute that presented, every student who logged in, every expert who shared, and every mind that learned. This anniversary is not the end of a year, it is the beginning of a legacy. Every great movement begins with a
Thank you. And now we request Dr. GBG George sir and Dr. Joseph Zon sir to take it forward from here and some words of advice, wisdom to us.
Thank you so much. I think, yes, it's been a year, and it's been a year of, I think, learning for both Joseph and me. It's been a fantastic set of cases, very varying clinical manifestations of varying hematological diseases that were presented during the last 12 months that we've had this webinar series. And now, to sort of top it off, we have this presentation from Malabar Cancer Center, and they're going to be presenting on stroke and sickle cell anemia. So we've got Dr. Chandran Nair, who's the professor and head of hematology and medical oncology at Malabar Cancer Center, and Dr. Kiran, who's a DPNP resident there. So we will go ahead with the case presentation. Over to you, Dr. Chandran.
Thank you very much, sir. So I must say that I missed this 1 year of great opportunity to be part of this program. And I sincerely thank Dr. Joseph and Biju, sir, for giving us this great opportunity. So I request Kiran to start the presentation.
Thank you, sir. Good evening, everyone. Is my slide visible? Audio is fine?
Yes, Kiran.
Okay. Good evening, respected faculties. This is a case that we would like to present from Malabar Cancer Center in Talasheri, Kerala. This is a story of a 10-year-old boy who was a third child of a non-consanguineous parentage and third child of non-consanguineous parents with normal immunization status and development, who was diagnosed in infancy as a case of sickle cell anemia following screening, as his brother was already a known case of sickle cell anemia. He was started on tap folic acid by the his initial pediatrician who saw him, and he was asymptomatic otherwise as per the parents. And in 2022, at the age of 8 years, he developed weakness of right upper limb and lower limb with slurring of speech. He was associated with seizure and facial deviation to the left. Hemoglobin at that point was 6.4 and peripheral smear showed was a of sickle cell anemia. And as documented in the discharge summary, the HPLC showed an hemoglobin S of 93. The imaging was consistent with left middle cerebral artery infarct, and he underwent an exchange transfusion, following which it was documented as an HbS value of 42. He was then initiated on hydroxyurea 250 milligram, folic acid, and was on penicillin prophylaxis. And he had subsequently received monthly exchange transfusion from January to May 2023, and after which he received no further transfusions. And during this period of exchange transfusion, he was fairly asymptomatic. And then in July 2023, he had a right focal seizure involving the right hand. And furthermore, he had like two more transient ischemic attack-like episode, which presented with weakness of right hand and associated with seizure lasting 2 to 3 minutes in April and May 2024. And then in June 2024, that is on 25/6/24, he presented to the nearest hospital with a new onset seizure and was associated with a right hemiplegia and associate right hemiplegia. An MRI and MR angiograph was done on 25th June 24, which showed 90% stenosis of terminal segment of right internal carotid artery with significantly narrowed caliber of right middle cerebral artery, left anterior cerebral artery, and paucity of cortical branches. There was no flow-related signal noted in the right posterior cerebral artery proximal segment. MR venogram was normal, and he was seen by a neurosurgeon and in the initial hospital, who advised an external carotid artery, internal carotid artery bypass to overcome this issue. And he attended our institute, Malabar Cancer Center, on 20th of June for further management, as well as for actually for advice on fitness for the surgery, for the neurosurgery. Now, on presentation to our institute, on examination, he was conscious but lethargic. Pulse was 118 with respiratory 24 and BP of 130/78 with saturation being 99. He was pale, icteric. There was no significant lymphadenopathy or pedal edema. Hemolytic facies was present. Anthropometry revealed a height of 129 centimeter and weight of 23 kilogram, which was in the lower percentiles, even though it comes in the normal range, but it was in the lower percentages. Per abdomen, liver was enlarged 3 centimeter below the right costal margin and spleen tip was palpable. CBC revealed a HB of 11.3. Total count was 8,830 with N7 neutrophil 79% and platelet of 4.4 lakh. Hemoglobin electrophoresis was requested and neurosurgery consultation was advised. And they went to another neurosurgery center where they had also done a 4-vessel angiogram, which revealed a bilateral moya-moya pattern. And MRI brain revealed a chronic left infarct. And in the tertiary center, the neurosurgery, they had opined to continue transfusions. Considering the fact that this child was free of seizures and fairly asymptomatic, as mentioned earlier, when he was on regular transfusion, exchange transfusions. And meanwhile, the electrophoresis that we had requested, they had reviewed with the report where the HbF was 17.6, HbS was 18.7, and HbD was 31.4, and HbA2 was 2.6, and which was consistent with a compound hetero for a HbD puncture bar HbS. So considering this scenario, we advise the hemoglobin electrophoresis of the parents. And meanwhile, he also underwent one exchange transfusion. And upon the next review, his CBCs were like HB 8.9. It would come down to 8.9 at the PC of 26.9. And considering this value, this time we opted for a simple blood transfusion. And during these episodes, he was like fairly stable. And then we had this HB electrophoresis of the both parents. HbF of father was 0.8 and HbA 58.5, HbD was 38.2 and HbA2 of 2.5. While for the mother, she had an HbS of 32.1 and HbA of 64. Consistent with the HB father having HBD Punjab and mother being sickle cell trait. Now, these are the serial values which we had tabulated from its whatever we could get from the earlier discharge documents as well as from during our institute. So, from earlier values of HBS, like about what was documented was around 91.8 and to around 43.8 by around December 2022. And in July 2024, at the about time when he presented to us around 18.7. And while being on follow-up, his latest two values being HBS of 12.1 and HBS of 14. And his HBD has been like 31.4. That was the first value. Currently, this child is on monthly blood transfusion. There has not been any further neurological events. And upon last review, this hemoglobin is 9.8. And currently, this child is on hydroxyurea, folic acid, levetiracetam for seizure, aspirin, and penicillin. We're currently also contemplating HSCT. And while the HLA with the eldest brother was 5/10, and a mud search has also been initiated. Thank you. This is so far the regarding story of our patient.
Joseph, you want to take it up?
I think Chandran has some discussions there on this, and then we can take up the discussion. Thank you, Dr. Kiran. Now over to Dr. Chandran for his critical thinking on this case. There are various unanswered coexistence of things we may be red herring on the HBS, right? Okay.
Yeah, so this case, we were not involved in the initial management of this case. So the case was referred to us for the purpose of two different questions. One is whether the patient has to undergo surgery, and second one is if the patient has to that surgery means revascularization. He had a critical stenosis of a few vessels, so that ended up in his stroke, and then secondary moya. And second thing is, if at all he's undergoing surgery regarding fitness, these were the two purposes he was referred to us. So in this is like a case of sickle cell disease, even though it's compound heterozygous, the behavior is exactly like a sickle homozygous. Am I audible?
Yes,
Yeah,
yes,
yeah,
yes,
please
yes.
go ahead.
Yeah, go ahead, go ahead.
He already developed a stroke before coming to us, and not only a single episode, multiple episodes. And what we can clearly perceive from the history that after the initial episode of stroke, he was receiving regular transfusion, regular exchange transfusion. That was from a different center, and for a period of around 5 months, January to May 2024, he was not having any further episodes of seizures or stroke. So he was doing well. After which, somehow the transfusion was like stopped. Immediately within 2 months, he developed second and then subsequently two more episodes, even though last two episodes of just TIA associated with seizures. So this is a case of stroke, and in which we have to think about what were the strategies we could offer for secondary prevention of stroke. So the first strategy is exactly what they were doing, like chronic transfusion has to be offered. So, which is clearly, I mean, as per evidence, it is clearly shown that if somebody develops a stroke, as a secondary prevention, chronic transfusion is the best policy. The question is how long to continue. It is mentioned indefinite period or even lifelong, as long as somebody is at the risk of developing stroke. And we know that if somebody has got a sickle homozygous, a single episode of stroke is going to end up in further recurrence of stroke, as high as 40% higher risk. Then the second question is some people may not be very willing to take up this transfusion on a long term. So they may be requesting whether we can switch to some alternatives. So there was a trial which looked at whether after some period of transfusion, whether it can be subsequently switched to hydroxyurea, which is shown to be like in case of secondary prevention, I mean, it is not found to be beneficial. That means completely moving away from transfusion, switching only to hydroxyurea is found to be inferior. So it is a must that people after developing a stroke has to be continued on chronic transfusion. Now the question is whether it should be a chronic simple transfusion or chronic exchange transfusion. There is no clear-cut data on this particular aspect, but guidelines do say that exchange transfusion will be better than simple transfusion. But we know the difficulty of even manpower involved if it is automated instrument, that instrument related issues, all those things. So usually we end up doing chronic simple transfusion, but only when patient has got the hemoglobin is on the higher side, say 11 gram or 12 gram already existing, then at some of the sessions we may end up in doing exchange transfusion. Otherwise, it should be chronic simple transfusion. So this was our first challenge we had to answer in this case, the strategy regarding transfusion. The second challenge is whether we should be offering this revascularization procedure from our side. I mean, neurosurgeon, even if they are ready to proceed for the revascularization, whether it is really beneficial or not. Even though, literature says that revascularization procedure has got some benefit and reduces further episodes of stroke, but the evidences are extremely less. I mean, published data with respect to evidences and patient numbers are extremely illness. So there's no clear-cut guidelines recommending somebody should be undergoing revascularization. So it may be a mutual discussion between the hematology team and the neurosurgical team, and most importantly, the patient itself, because each surgery in a sickle cell patient can be of very high risk, like even including mortality. These were the two main challenges that we had to face in this situation. And what was finally decided, now the patient is currently on regular transfusion with no further episodes of stroke. Second thing is surgery was not done because the neurosurgeon was also of the same opinion that while receiving regular transfusion, patient was free of stroke, free of seizures. So let us see how he does with the chronic regular transfusions. And we also became safe. The patient also is doing well. So fortunately, patient is not having any further episodes of stroke, so he's maintaining. So this is the current scenario. These were the two challenges we had to mainly face in this case.
So, Dr. Chandran, thank you so much for the discussion. I have a few basic foundational questions to ask you. One is, here the diagnosis is HPDS and not HBSS. Statement number one. How can we explain the HBS of 91% upfront? And how can an heterozygous be presenting with an HBS phenotype? Is there any thoughts on that?
The first question, this HBS of 93%, I think it can be a documentation error. Because subsequently, when we performed the hemoglobin electrophoresis, it was within limits, like HBS and HBD were represented
So,
in what
one
was
second, did you
expected to be
do HPLC or was it an
HP. What
electrophoresis?
we did was HPLC.
What outside done was
What
HP
was done from
electrophoresis.
outside, we don't have the printed report. It is just
So,
documented
it
in
must have
discharge
been a
summary.
co-illusion which has probably happened,
Likely,
which would
because
have given a faulty. That
similar
is number
movement,
one.
probably.
Number one. Number two, it is the Moya. I was also looking up. It is not that something which we see very commonly in Punjab, but HBDS is a little unlikely to cause Moya Moya. Moya Moya is something because of recurrent strokes, they say, because of the smoke like appearance there, because of that. Now, is this finding in alignment with an HBDS as such, or is it something unusual, or is it a coexistence or something else?
So I was also looking at the literature. It is mentioned that apart from HBS beta zero thalassemia, this is one of the variant HBS HBD, which can have manifestations similar to a sickle homozygous.
And
We
in
haven't seen
such,
many cases, but this is mentioned in literature.
so you must report this, I think, because Moya Moya is not something which we often see. And also, from a neurosurgeon's point of view, the thoughts we have is what are the indications for their revascularization strategy, considering he's not a sickle. If he was not a sickle and you had the 90% stenosis and a Moya Moya finding in the brain, would they go and do a revascularization? If they do, are they going to do surgical or they are going to do stenting?
So these details exactly, I am not very sure, but we could not directly talk to the neurosurgeon. What I understand is it is like a bypass sort of thing, not like a proper surgical procedure. And different surgical methods are mentioned, and of which one type is a bypass type of procedure, just to bypass that critical stenosis area.
Okay. Now, is there any literature says you have done in a sickle cell patient with a stroke like this? Is it an indication? What is the age again? You said around 20s, no? What was the
10, it is
age?
now 10.
10 years.
Yes, sir, 10
So,
years.
is he a candidate for a stem cell transplantation because he is behaving like an HBS? And is there any uh, you know, associated genetic abnormalities which is pushing the phenotype something other than HBD?
Okay, so the transplant in sickle cell, even now, what I feel is a quite gray area. One is this patient doesn't have a, mass sibling donor. That is one point whether we should upfront go for a transplant or not. That is one question. Second thing is Usually it is mentioned that if a patient with sickle homozygous or a genotype which behaves like a sickle homozygous has got manifestations or complications which are not easily managed by standard of care. I mean, regular transfusion or hydroxy, not all, even with hydroxyurea, if they are not able to maintain quality of life without recurrent complications, such patients have to be considered for transplant. Other indications are mentioned are like this patient, for example, this patient is requiring regular transfusion just because he had stroke. So if somebody is requiring regular transfusion, either because of a severe hemolytic anemia or indications like this, like stroke requiring subsequent secondary prophylaxis. Those are the situations where we can offer stem cell transplant. But if somebody doesn't have a mass sibling donor, whether we should jump and do the transplant, that is a questionable. Mutual discussion between the physician and the patient.
So we have some questions on the chat box. One is Dr. Abhay Saurabh Bhave is asked, and also Dr. Arihant. One is they also agree that there is electrophoresis can co-elutes along with HPS, HPD.
Yes.
But what is the HPLC and the clinical behavior of the elder sibling?
So the elder brother is actually currently around 24 years old, and at present he is like for being followed up from a hospital in Karnataka. So like his parents are in a different place they are residing at present. He has had some vaso-occlusive crisis with some pain syndromes in the like hand syndrome was there. At present he is on Hydria, but like he's working there and he's like being followed up from a different hospital like setting, and like they at present the parents and the child is staying in a different place at present. We don't have any currently any medical records of this second brother as of now.
Is he HBSD or we don't know? We don't know anything about
No,
it.
sir, we don't know. Like what they have told is he's like we haven't seen the report. We have been told that he was a case of sickle cell anemia. Uh, that's we don't have an original report of his HPLs.
Geographically, HBD and S are common in Malabar.
No, so
Like,
we don't have so many cases of sickles
so
only because
are there
just because
migrants
this
from
case
Punjab
was
and
no,
North
no.
India, or they are only from
We
Kerala?
are nowhere,
Tribal.
nowhere near Punjab.
Yeah, so
Okay,
that's
the
the
parents.
question. Do we know the origin of the father? Is he a migrant from somewhere there, or is it true Malayali? Because
Basically from Coorg, if I am not mistaken.
Yes,
Coorg,
okay,
isn't it, Kiran?
yes, sir. They are at present staying in Kasargod,
Ah.
but originally they are from Kerala it's only. But the father has like in the Karnataka Kerala border towards the north.
Any
Mother is like
mutations? Did you do any genetic abnormal, any genetic studies, NGS or anything on them?
have we done mutation? Yeah, that's true.
uh, no, sir. We
We
haven't.
did not.
Yes.
Okay. Any other queries regarding this on a sickle? I mean, this sickle, I mean, in general, sickle, Dr. Biju, and any of the consultants here on the discussion forum, we are happy to discuss sickle and transplant, which we don't really say. We say we are Arab and do not require transplant, but we generally hear about sudden deaths. Dr. Aruna has put on her camera on. Any thoughts on sickle in India?
Sir, we had an opportunity to transplant two patients with sickle cell. It is a very different experience to transplant them. And the first boy was from, actually, the first girl is from Maharashtra with a fully matched sibling. She had AVN and pain crisis despite being on hydroxyurea. So the sister was a sickle cell trait, and they had she had a relatively, it was a matched sibling donor. We used busulfan fludarabine based conditioning, and she did relatively well along with rapid TTG. The second boy was from Kerala, so he's from Wayanad, that area. So and he had a matched sibling, and he had sickle cell hepatopathy at 16 years of age. And he had a fully matched sibling. The sibling was 2 years old. She was the fifth in order of the five children. The first had sickle cell anemia. The last child has a fully matched donor. So, and that was one of the toughest scenario where we counseled them against transplant because of the weight disparity and a 2-year-old donating for a 16-year-old, and the 16-year-old with sickle cell hepatopathy who has had many issues in the like for the last nearly 8-9 years. So he was a very high risk, but actually he is now nearly 1.5 years post-transplant, and he has done. Though he has had post-transplant issues like influenza, pneumonia, he had a cholecystectomy for symptomatic gallstones, but related to sickle, he has become symptom-free.
Wonderful.
So I
So, any
think,
preparations for the?
but all these
Yeah,
patients, yes, sir.
go ahead. Go ahead.
So all these
No, I
patients,
was asked.
well, actually, we took multiple inputs from various consultants who do sickle cell transplants, and we had given them 6 months of levetiracetam post transplant. We maintained low cyclosporin levels, like between 100 to 150, preferably on the lower side, and many like their magnesiums were kept under strict monitoring because they were prone for press in the post transplant period. And we did a very slow tapering of cyclosporin to avoid GVHT.
Yeah, so we can manage with a mixed camera here, and we don't have to worry about a full chimerism, right? This
Yes.
is, and then any preparations for the donor specifically who's a carrier when you're giving GCSF.
Yes, sir. So this also we discussed. The first donor who was a match sibling donor. We had gone for a marrow harvest. And usually in the marrow harvest that we do here, we give GCSF stimulated marrow. So we checked with all these experts, and all of them opined that the sickle cell trait donor can be given GCSF, but not for Plerixafor, to avoid Plerixafor. So we gave GCSF for the first donor, and she did well, and she had no issues. And whereas the second child is a 2-year-old who's donating for a 10 kg child, donating for a 45 kg patient. So there we still gave GCSF, but we could not go for the marrow harvest because of the huge disparity in weight. So we had a catheter in for the baby, and she donated peripheral blood stem cell. Again, having the catheter in was a because they are prone for thrombosis. So all these we took high risk informed consent from the parents, and but she also did well. And both the patients who have underwent transplant, we pre-transplant, we brought down their HbS to less than 30% before taking them up for transplant.
So, is it that the donors should never be on a PBSC if they can donate marrow and
No,
the
sir,
donor
to avoid GVHT, we wanted to use their marrow, sir.
marrow?
Yes, sir.
Okay. And always rabbit ATG with flu conditioning, right?
So the first child we gave busulfan fludarabine rabbit ATG, whereas this boy who had sickle cell hepatopathy, we gave triosulfan fludarabine and a reduced dose of thiotepazole. So instead of the 10 mg per kg, we gave 5 mg per kg thiotepa.
So you don't do ATG there.
No, so we gave ATG. So all of them, or both the patients received ATG, but it was busulfan based for the small kid who was, she was 6 years old, the first child. The second boy who had a hepatopathy, it was triosulfan thiotepa based, reduced dose thiotepa. And both of them received fludarabine and rabbit ATG for lymphodepletion. Yes, sir.
Good. That's a lot of insight. Dr. Biju, any other queries you want to?
No, so we've done about 20 transplants for sickle. Most of them are from Oman and Nigeria and all, but we use Flutrio Thiotepa with ATG. And we use only PBSC, we don't do marrows. The only thing
And
is we try and make sure that the counts don't go up above 40,000 when we are giving GCSF to the donor if
Yes,
the
sir.
donor is a sickle, heterozygous.
Sickle trait, no, sir?
Yeah, sickle trait also we give G, but we try and make sure that the WBC counts don't go up too high. So about 20 to 30,000, we will make sure it doesn't go above that. We may omit some doses of GCSF if we need to.
So that will be like daily CBC will be monitored.
Yes.
And what is the explanation for no pluric suffer, like Aruna was telling?
So what people have
Sir,
said
that
is that,
sir.
go ahead, Aruna. Go ahead, Aruna, go ahead.
No, sir. You give a better answer than me, sir. Yes, sir.
No. So they say that when you're sort of pushing it into the system, the stickiness actually is much more. So because the stickiness is more, you may end up having more thrombotic risk. So that is why I think there is one question of somebody's asked, I have a sickle cell trait having stroke.
Stroke.
So exactly the same thing. So under anesthesia, if you're dehydrated, even a sickle trait can develop a stroke because it will precipitate sickling. So although the percentage of HBS is low, but that is enough to all of that will sickle and produce a stroke.
So, look, Viju, one question from my side. I'm just thinking loud. Thalassemia, we are all going ahead and aggressively transplanting between 2 to 7 if there is a possibility of a donor. Whereas sickle, we have been not really pushing hard, and but then we are probably missing out on sudden deaths among sickle at the age of 20 or 30. Now, is it time for us to make a campaign and say, yes, we must include sickle into the Coal India project or promote sickle transplants at an early age?
Joseph, I would say one of the reasons why we have not been sort of transplanting sickle aggressively is because we believe that the phenotype is milder, it's the ORM phenotype, and so many would do well with hydroxyurea. While saying that, we know that the sickles who come in different, so the sort of the concentrated bells, so Wayanad, the ones from Nilgiris, the ones from Kur, they behave typically like the African sicklers. They get recurrent crises even from Maharashtra. So they definitely will need to be. Now, what is the outlook of a sickle cell person who's well controlled on hydroxyurea? I'm not sure they will live up to 70, 80 years. Their lifespan definitely will be shorter. And once they reach 30, 40 years, pulmonary hypertension, sickle nephropathy, all that will come in. So I really think we should push sickle transplants the way, because at least for us, among the sickles that we have done, we have about 85 to 90% when it comes to match sibling.
Yeah. So that means that we must push. Now, I
We
don't know
must push.
anybody here. Dr. Cecil, Dr. Arihant is here. Any thoughts on this aspects? This is something which is nationwide. We have to keep the alert while we are campaigning for preventing sickle with various aspects. Any thoughts, Dr. Arihant, Dr. Cecil, any of the previous consultants who have joined us? Hi, Dr.
So,
Cecil.
hi. I because we do get few occasional sickles. I mean, not sickle. I mean, quite a few sickles that are there in Karnataka, but we have not thought of transplant because they just have exchange transfusion periodically because of severe painful crisis and things like that. But you not really consider transplant in them because I think sickle transplant is a different ball game.
Yeah, but then on the other hand, I would say if so, for example, if you go to the UK, they will put them on a fantastic transfusion replacement regimen, and those people have a normal lifestyle. So we should have these centers who are able to do this exchange transfusions month in and month out and look
Yeah.
for all these complications. They will have a normal lifestyle. The problem is, I am not sure how many centers are there in India who will be able to do that. So
Yeah.
if you're not
That.
able to
Yeah.
do, we compromise.
So then your question of introducing into Coal India, Joseph John, is that you have to improve the centers that can actually give external transfusion or improve the capacity because anyway the PM's the slogan is sickle free Bharat and all. No, so under that you have to improve the infrastructure and the awareness and the capability of the laboratory and the clinical expertise in the blood bank or transfusion medicine or medicine, whichever, to be able to do external transfusion. Because sometimes many centers are able to do external transfusion in severe malaria. Okay, when the parasite count is quite high, you are doing external transfusion manually. You don't need anything. So I think that the stress there should be, instead of transplant and all, must improve the basic infrastructure, capability, capacity, and that sort of thing.
Yeah, but I mean, I would argue the other way. We see these patients
Yeah.
now from Bihar who come,
Yeah.
adults who come for transplant, and they
Okay.
are coming with spleens which are 12, 13 centimeters, 6-year-olds. Ask them what happened. They get transfusion once in 2, 3 months, although they are supposed to get every month because blood is not available. In a government program, if a blood is available, they get it. If the Xerox is available, they get it. If not, they suffer.
Yeah.
Unfortunately, that part is sort of neglected. If we could do optimal transfusion chelation or optimal exchange transfusion, yes, we may not need to think about transplant. But when we don't
So,
have that, and I assume that more than 90% of centers around the country don't have that, then
no,
an
no, Biju.
exosuction is worthwhile looking at it.
Biju, see, in the NHM, there are integrated daycare centers, okay, which take care of sickle, thal, and hemophilia. Okay, those centers are functional actually. Okay, now the transfusion is really not that much in hemophilia, but the thalassemics do get good transfusions in centers that are actually got allotment, both funding as well as staffing, and there are dedicated staff. Now, out of say 150, 200 centers, at least 70, 60 are okay, not too bad. But the point what I'm trying to say is that you have to do awareness, improve the infrastructure, give out awareness and all, like what you've done for hemophilia. It's quite okay. I mean, your government is sanctioning. Now, the problem in hemophilia is a little different in the sense that procurement is that, but this sickle, at least in Karnataka, we meet once in a month, once in 2 months to discuss what is happening to each of the patient in different districts of the state. So there are centers. Now that depends on the local leadership and the patient advocacy to be able to provide the blood transfusion and things like that, which is anyway free by government order, is free. So sometimes what happens, the patients don't go to the blood centers to receive blood transfusion for various reasons, especially in a city like, I mean, a state like Bihar and all. Maybe the transport, the availability, the other socio-economic status may be there, but at least in the southern states, the integrated centers are doing reasonably well, I'm told.
Yeah, I
So,
think
sir,
that's
can I butt in here with the
Yeah.
two opposing points there? I tend to lean towards Dr. Biju's approach there. If you want a Bharat of sickle-free Bharat,
Hmm.
we need to take a both and approach rather than either or. And when you have to do, we have to do a full court press. When you say full court press in basketball, we say all aspects are covered man to man. It is not when it comes to you, you will address it. So one side is prenatal screening happening, like antenatal screening, which is happening. One side transfusion to be done, exactly like what we are doing thalassemia. Now, if you look at the indications for transplant, that is stroke, moya disease, recurrent crisis, hematological complications, ultimately they may all have nephrotic syndrome or kidney abnormalities. Nephrogenic complications will be there. So while we improve the background, people, 25% of them will have a match. Even if it is a carrier, you go ahead with the transplant if it is in the suitable age. Since we are discussing policy, I don't want the 100 plus people sitting here and listening to this saying that we should not achieve transplant. That is something, a thought process we need to go to transplant as well.
Sir,
No, so no, no.
the
So,
best
so this
age
the
to
total number
transplant
of
is, sir.
sickles.
No, no, one sec, Dr. Cecil, Dr. Aruna, let her speak and then
Yeah,
we'll come back to
yeah,
you.
yeah, yeah.
So the best age to transplant is less than 10 years, sir. So this is $1 million question. Who is the right patient in sickle cell to be transplanted? Because less than 10 years, the disease is getting modified with hydroxyurea. But as they grow into adulthood, they overgrow the effects of hydroxyurea and they become even symptomatic, which is not related, which can be modified by hydroxyurea, like venous thromboembolism, pulmonary thromboembolism. All these seem to be a major issue as they grow into adulthood, sir. So this is a $1 million question. Who is that patient who has severe disease but requires transplant before they develop end organ damage. So taking up a patient who has developed stroke for transplant is not what we do in hematology, sir. So we have to find out this patient who's at risk for stroke and take them up
Yeah,
for
so that is
transplant, and yes, sir, with the intact survival.
yeah.
So
So that
like
is when the
doing
disease that is where disease modifying polymorphisms come in play.
yes, sir.
And since three of us are promoting transplant here, I want to hear Dr. Arihant, who was talking about role of mitapivir and it's a tongue twister, crizanlizumab in thalassemia. I mean, in sickle cell. Hi, Dr. Arihant.
Arihant,
You're
you're
muted.
muted.
You're muted.
Hello, sir. Yeah. So as me and Joseph sir work very, we are kind of neighbors, and at least in this part of the world, uh, sickles are very rare. So our experience is limited. But one thing is that sickle is predominantly a tribal disease, and somehow from what we gather from our colleagues, the government programs are really keen, and they have adequate funding with respect to the tribal health is concerned. And they would, if the right way is approached, probably the funding should not be an issue. But as Dr. Aruna said, we need to find the right persons who can go for transplant. And then there are these a lot of drugs which are coming up, and sometimes they come, and then they like voxelotor, L-glutamine, others which do benefit, but somehow the companies, at least in the West, have taken them off. So that's what my thoughts are on this topic.
So, Arihant, I should say, I know that crizanlizumab, I think in the phase 3 trial actually failed.
Yeah.
So, because of that, the FDA has not given approval. The
Mhm.
mitapivat is more for the sickles who are sort of transfusion dependent rather
Mhm.
than the ones who present with recurrent
Strokes.
vaso-occlusive crisis. And in
Yeah.
that, I think the early data seems to suggest that it helps in reducing transfusion frequency.
Yeah. So would it be different for the haplotypes which we have? I mean, would the drug behave similarly, or would these drugs?
Yes. So for me, I would say if I see 30, 40 sicklers a year, I would recommend transplant in only 5 out of them because a lot of them seem to do well. The ones who say come from Chhattisgarh and all, they seem to do well with hydroxyurea. And if they
Yeah.
are transfusion dependent, and especially they are on the older side, like Aruna said, because I know the ASH recommendations is that you should transplant below 12 if you want to have best results. So if they are doing well and they are older, you don't want to go and do more harm. So you would go ahead. I think what we should try and focus is on the patients who get these recurrent crises, because then they develop avian, stroke, all that. These are the people who would probably benefit the best from a transplant.
Yeah.
So,
Yeah.
is there any biomarkers or polymorphisms which we can have, which can predict the necessitation of a transplant?
No, yeah, no. When I looked at it, see, the thing is that if you have got associated alpha or some other issue, then that protects sickle. But otherwise, the phenotype of sickle that we see in India compared to what you get in the Africa is totally different. So, out of all the sickles that are there in the population, very few actually have all these complications that actually necessitate transplant. In the sense, like the recurrent transfusion dependency, splenomegaly, despite transfusion, all those kind of things, or recurrent sickle crisis and things like that. There are very small number. Those I agree that you have to do transplant, this, that, and the other. I'm not saying, but as a policy, majority of the sickle fellows are quite okay with hydroxyurea and folic acid. That's my understanding.
So, my question is, does anybody know the life expectancy of a sickle in India as opposed to this thing? Does he get 67, 70 years as this thing, or it is much lower? That's a moot question we are asking, no?
is
And then
lower. Yeah, it is lower because of transfusion and this and that and the other is lower. It's not like normally 65, 70, that sort of thing. Because you see that sickle society, whatever, of India, there's one chap. Okay, they actually have got a good follow up and a good hold on patients with sickle cell, and they actually do a good job in advocacy and getting transfusion and hydroxyurea available for all the sickle fellows.
See, the
Which is
sicklers that we see, once they go above the age of 30,
Hmm,
most of them would have had avian, then other
correct,
stroke.
correct.
So, we're
Avian,
reaching
yes. Strokes, I'm not too sure. Avian, yes.
so,
Fellows are asymptomatic, fellows have avian. The fellow never had joint bleeds in there, but incidentally the fellow discovers that he's got AN because little.
but
So
these
these
are
are
all
not symptomatic
vaso-occlusive
or never
crises.
had pain in the hip.
But these are all vaso-occlusive crises. So that is why the question of those who have VOCs, whether they would benefit from doing a transplant early, because definitely it looks like their life expectancy may be reduced as compared to, say, a transfusion dependent sickle. Because we look at the Northeast, you have a lot of sickle betas.
Yeah,
And
yeah.
the sickle betas present mainly with transfusion dependency rather than with more recurrent vaso-occlusive crisis. So they may do very well off with hydroxyurea, or if you do mitapivat, other drugs. Mitapivat is still not available, but if it comes in, then that is something to look at, because that will help in reducing the anemia.
But Biju, many people I have seen, at least in our tribal population and non-tribal population, these fellows have never had any pain in the hips, but they have avian.
Avian.
Okay. And the only thing when you discover that they have some other crisis, then you figure out the fellow's got avian. But the fellow never had a history of avian at all. So these are asymptomatic. So if those people maybe are asymptomatic and you got some kind of end organ damage, those maybe you need a transplant because that fellow may have other end organ damage silent. But majority of the people are not like that. I mean, sense that they are, I don't know, because the total number of sickle cohort we have is quite reasonably well managed. In fact, in Mysore, where this patient came from, Mysore, Kasaragod, that tribal area in Mysore, Chamarajnagar and all, very good cohort of more than 300, 400 patients. They are there and doing extremely well with a lot of periodic monitoring and things like that. There's a group there. So, like that, I think you have to improve the local awareness and the local interest. That's what I'm saying.
See, can I give a perspective to that, Cecil? See, while we say patients are doing well with complications, so morbidity is high, number one. Number two, we are not accounting. See, thalassemia is something, if you don't transfuse immediately, they'll have problems. By 20, they
Yeah,
will
yeah,
die. And
yeah, yeah,
therefore,
yeah,
we
yeah,
say we
yeah,
must transplant.
yeah,
But the
yeah.
life expectancy in India, in lot like Dr. Biju said, in LMICs is 30, 30, 35. So
In sickle,
therefore, yes, that is one of the. I mean, I'm doing some search side by side, and I'm seeing 35 to 40 is the average Indian publication which is coming in as this thing, which is probably some good centers. But other centers is probably the unknown unknowns which we are dealing with, right? So maybe it is some. I mean, maybe whoever listening here can look up some search and see what are these systematic reviews on what is the sickle lifespan and give a case on transplant.
So worldwide, the lifespan is 40 to 59 years, sir. Which is 20 years at least lesser than thalassemia survival. Survival of thalassemia has reached 55 to 70 years. But sickle cell survival is they have a high mortality at the age of 40. Even if they are in US or UK, at between 40 to 50, so their longest survival is 40 to 58, 59 years.
So if we are
Whereas in
looking at
India,
that,
sir,
we are looking at probably 10 years lower when we look at something like India.
is Whereas our
So
Indian
ideally,
average lifespan is more than 70, sir. So, comparing to our own average lifespan, the sickle cell anemia patients are going to live at least 30 years younger than them. They're going to die 30 years younger. But when I was in Nilgiris, in one of the areas, their maximum longevity was 18 to 20. That is at the age when they are like an adolescent or young adult, they usually succumb to the various complications of sickle cell.
so
So,
Dr.
but there are
Iyer,
pockets like that, Karuna. There are
Yes,
pockets
sir.
like that,
Who
like
have severe
Nilgiris.
disease. Yes, sir.
Yeah, like Nilgiris, like Kalahandi, okay, in Orissa. those are pockets where every other fellow is sickle and the mothers are sickled and the
Yes,
children
sir.
are sick.
There is a
Those kind
variable
of
disease, sir.
highly endemic
Yes, sir.
and the incidence of non-tribal fellows getting worse sickle is much more than the tribal population. The non-tribal fellows get worse off in areas like Kalandi and parts of Orissa. So those are pockets of them which needs intervention.
Yes,
So
sir.
therefore, I'm saying those areas you have to bring about. But if you take the
Yes.
general population and average it out, they're not too bad. That's what my understanding is, because the interventions
And
are
this
simpler.
transcranial Doppler is what the textbooks and all
Yeah,
is
correct,
often
correct.
spoken
Yeah,
about, but may
yeah.
not be practiced
Or I
in
do not know much
wide
about it. Yeah.
angles.
Actually, the recommendation in children is that you have to do yearly transcranial Doppler in sickle, and as soon as you find that the velocities are dropping, you have to take them up for transplant, or you put them on a
Absolutely.
hypertransfusion exchange program.
Yes.
But probably not
So,
very feasible in India.
So, any comments on alternative donors?
Yeah, we've done Haplos,
How did they do? Like
60%, 60%.
60 PTCY.
With PTCY. We have done both PTCY and alpha beta depletion. This fellow has got very good data. So who's this? Gaurav Kharia with doing alpha beta depletion in sickle.
yeah, even Sunil Bhatt has the data, no?
Sunil has also got, yeah.
So, Arihant just shared the NHM guidelines on hemoglobinopathies. Arihant, does it say sickle? They say we can transplant, but does it say we must?
So that's what I was trying to search in the guideline as well. So I think it's a very brief. They have given the budgetary estimate of a transplant for a sickle Barthel, but they have not put on the uh, exact criteria as to who should be taken up for transplant.
Yeah. Okay. So that is something which we need to create some awareness, because probably it is an unknown which is going. We must originally look at it. Okay,
So
so we have discussed from a case of Moya Moya. Maybe as part of indication in a homozygous sickle with Moya is an indication for transplant, but an HBDS is something we need to find out if it is required or not. So, Dr. Biju, shall we? The good
Are there
discussion
any other
appear.
questions? There's one question no, in the question and answer. So question of does voxelotor prevent stroke in sickle cell disease? I think there is data to show that voxelotor both improves the anemia as well as reduces the stickiness. So it is useful in sickle cell disease for that.
But
So,
it is withdrawn because the
yeah.
latest data is showing harmful, like increases the occlusive episodes.
So right now the only drug actually which you can use is L-glutamine.
Yes, yes.
Okay, so to wind up, thank you all. That is a wonderful discussion, Chandran and Dr. Kiran, for taking up this case. And it is a true case discussion for the finale of the 1 year completion. And we discussed from case presentation to even policy making. Thank you, Dr. Cecil, for have that opposing views. It is good to have some discussions on that aspect. Thank you, Arihant, for chipping in. Thank you, Dr. Biju. And over to Deeksha.
Thank you so much, sir. So, as we bring this very special session to a close, we stand together at a truly meaningful milestone. With today's 12th episode, Blood the Life Savior completes 1 full year of impactful academic learning and nationwide collaboration. What started as a vision to unite institutes, clinicians, and young DM/DNB students on one scientific platform has now grown into a strong academic movement across India. Today's episode would not have been complete without our distinguished panel. Dr. Chandran K. Nair, thank you for your thoughtful summary that seamlessly captured the important lessons shared in today's session case. Dr. Kiran for his very well presentation. Thank you, Dr. Cecil Ross, Dr. Aruna Rajendran, and Dr. Arihan Jain for your presence with us and your impactful thoughts. Our deepest gratitude to our course directors, Dr. Biju George and Dr. Joseph John, whose unwavering academic leadership, vision, and commitment have guided this initiative from its inception to this very proud one-year milestone. To all the institutes who were with us over the last 12 episodes, to all the clinicians and the residents who joined us month by month, and to everyone present here today, thank you for being a part of this journey and for making this platform truly national and truly meaningful. With 1 year behind us, we promise to carry this journey ahead, even with greater commitment, driving education, insights, and clinical excellence in hematological disorders. Thank you once again for joining us today on this special anniversary episode, and we look forward to welcoming you to many more insightful sessions of Blood the Life Savior. Have a wonderful evening. Thank you.
Thank you all.
Thank you so much.
Thank you, sir.